Kia ora, everybody. We'll have a few more bing bongs as people join the meeting. So Jesse Gale is my name. I'm an ophthalmologist in Wellington, and I did this talk for our Wellington Glaucoma New Zealand group, and it was their idea. Some of my patients who are in that group had the idea that they'd quite like a tour of the glaucoma clinic and see all the gadgets that we use. But when we thought about the logistics of that and trying to get patients into the clinic when it wasn't full of other patients and teach them how to use the equipment, it wasn't really practical. So we made a kind of virtual tour of the doctor's perspective of a glaucoma clinic. And hopefully it's interesting because it kind of, it shows you what all the gadgets do, but it also kind of focuses in on what glaucoma is and what we're looking for in the clinic. So we should have plenty of time for questions at the end. So this first slide is about when we're testing vision. And obviously testing vision is one of the most important things that we do in the eye clinic. When we get people to read the chart, that's testing the resolution of the very central vision, and that's known as visual acuity. But in glaucoma, generally the visual field is affected before the visual acuity is affected. So most people with glaucoma have normal visual acuity. They can read most of the way down the chart, but their peripheral vision is affected to some degree. And I've got a couple of slides about measuring visual acuity and what the pinhole does. So this is an imaginary scenario of someone with a normal eye who just happens to be short-sighted. So the light coming from the distance, the rays of light are roughly parallel, and they're focused by this eye in front of the retina. And by the time they get to the retina, there's a blurry circle. And so you can only just make out that the top of the chart is an A. It's pretty hard to read anything when you're very short-sighted. And when you put a pinhole in front, it's essentially eliminating all those parallel rays of light down to one ray of light, so that it leaves a much smaller blurry circle on the back of the eye. And it's kind of much more independent of all the optical factors at the front of the eye. So a pinhole will correct nearly all optical issues in the front of the eye, whether it's a cataract or a funny cornea or just being short-sighted. You can make a pinhole out of a piece of paper if that's helpful, but because it blocks out so much light, these pinholes, even though they can make your vision much sharper, are not usually practically useful in day-to-day life. And they don't tend to make the vision quite as sharp as if you have a correct pair of glasses that brings all the light into focus on the retina. So now we're going to just do a little tour of visual field machines. And in order to do a visual field correctly, you need to put a lens in front of the eye that brings the bowl of the visual field testing machine into focus. So usually how we do that is by measuring the patient's glasses first, and then entering those details into the visual field machine, and it tells us which lens should go in front of the eye. And the lens needs to be positioned really close to the eye so that the lens holder doesn't block your peripheral vision. And we quite often get visual fields where the lower half of the visual field has got lots of missing targets that were missed around the lower edge of the visual field because the lens was not close enough to the eye and the lens holder got in the way of the person's peripheral vision. And when we're sitting on the side of the visual field machine and the patient's doing the visual field machine, we get a little infrared video of their eye so that we can tell that they're staring straight, and we can make little adjustments of the chin rest during the procedure to keep the eye in the center of the lens. And most of you will have had a go on one of these things. It's everybody's least favorite part of being a glaucoma patient. And a visual field test normally takes somewhere between 3 and 6 minutes per eye. And so this is a example from our volunteer who kindly gave us permission to share all her information. And there's just so much information on here. I'll just walk you through it because it's an amazing device. There aren't any nerves in neurology that you can scrutinize with as much precision as you can the optic nerve. And what we're getting here from all these different parts of the visual field is a measurement of the sensitivity, and our brains are not capable of looking at these numbers and making sense of them. So it shows them as a grayscale image here. But on this side, for example, you still can't tell whether these gray tones are normal or not. So they take all these numbers and compare them to other people the same age, and that gives you a deviation from normal. So on this eye, the right eye, there's a few spots here that are 0, meaning that they're perfectly the same as average for that person's age. There's a couple of points that are 1. Sorry, my pointer's disappeared. There's a couple of points that are 1 or 2 where the person is above average for their age. And then there's a few points where they're 2 or 3 or 4 points below average. But each of the points in the visual field has a normal value, an average value, but also a range, a standard deviation of what's normal. And so in order to understand whether -4 is normal or not, you have to do a statistical test. And that shows that none of these points are really statistically abnormal. On this side, you can see that some of the targets were not seen even with the brightest little light. And so they get a value of 0. And then others had a sensitivity of 3 or 5 or 7. And these values were substantially below normal. They were -25 below normal, -34 below normal. And statistically, those were abnormal on the statistical test. So all of these black squares are ones that are less sensitive than normal. And that kind of makes sense. In this particular example, you can see this black area in the visual field, and it looks obviously different to the rest of the visual field. And sure enough, it's truly an abnormal result. So the reason I sort of went through that really slowly is that a visual field test, it takes only 5 minutes, even though it feels like the longest 5 minutes of your life. But it gives us the most detailed assessment of the optic nerve function compared to any other test or any other neurological test of nerve function. So we're very lucky in ophthalmology and in glaucoma to be able to measure the function of the optic nerve so precisely. Then when it comes to looking at patients, most people with glaucoma look pretty normal from the front. Sometimes at arm's length, we can see things on people's eyes from a meter away that give us information about their history. You can see that this person, when she looks down and you lift her eyelids up, she's had glaucoma surgery. There's a little sort of white bleb on the top of her right eye, which you wouldn't notice from looking at her straight on. And sometimes from arm's length, we can recognize side effects from our drops. This person's been using latanoprost in her right eye, and you can see that the upper lid has got a little less fatty tissue, and the eyelid skin is a little more pigmented and red, and the lashes, you might have to take my word for it, are a bit longer. And maybe even the iris is slightly darker on that side, although the light's coming from her left. But these are all familiar side effects of long-term use of latanoprost, travoprost, or bimatoprost. You can see her long lashes when she closes her eyes. But generally we zoom in, and this is our microscope that's the same all around the world, and it's called a slit lamp. And the reason we call it a slit lamp is that it works really well if we make the light into a thin slit. And the reason that's helpful is that in this example, you can see the light is coming from the left-hand side, and here it touches the front of the cornea and gives us an optical cross-section of the cornea, and then it comes out from the inside of the cornea and goes across the aqueous, the anterior chamber, and then it hits the front of the lens and the iris, and it gives an optical cross-section through the lens. So making the light into a slit is very useful because it gives us more information about the the forward and back, anterior, posterior, Z axis, and it sort of enhances what we can tell about the third dimension more than a photo. So we look in the front of people's eyes, and this is our volunteer again. And with diffuse illumination, we can just sort of see a fairly normal iris with some little freckles, which are totally common and benign little pigmented blemishes on the iris. We can see that she's got a little bit of redness and congestion in her eyelids, and that's a very common finding called blepharitis. Nearly everybody's got some of that if you go looking for it. And when we zoom in, we can use the slit beam to give a cross-section of the lens, and we can see that's a normal, healthy, clear human lens with a slightly greeny grey tinge to it. And we can focus on details in the iris and see the beautiful pupil ruff. The pigment on the back of the pupil is always a dark brown color, even if the front is quite a pale blue color. And that dark brown pigment on the back of the iris just visible at the pupil edge. And you can see the sort of feathery, beautiful texture of these little freckles on the surface of the iris. And sometimes we put a contact lens on the eye. You can see the iris down here, and with this contact lens, there's a little mirror inside it, and it shines a light down across the anterior chamber into the little space where the edge of the iris meets the edge of the cornea. And the reason that this space is important in glaucoma is that there's a very faint structure, not very easily seen on this slide, unfortunately. This person's got quite pale pigment in her eye, and she doesn't have darkly pigmented structures in the corner here. We often call this structure, this area at the edge of the iris, we call it the angle. There's lots of unfortunate and unhelpful jargon in ophthalmology, but this area called the angle, or the trabecular meshwork, is the structure where the clear fluid of the eye is pumped out into the blood. And the reason that's important, I'm sorry, it's not very well focused, but there's a thin band here of cells that pump the clear fluid back into the blood. And if they are dysfunctional or blocked or damaged, those cells can't pump the fluid out fast enough and the pressure goes up. So usually if someone has a glaucoma problem, especially a glaucoma problem with a high pressure, it's because of a problem with these cells. So now we're looking at this person's left eye, and this left eye has had quite a story already. Just from here, you can see that she's has a slightly different reflection from the pupil, and that's because she's had cataract surgery. And you can make out there's a sort of translucent sausage-shaped structure over here, and another one down here. And those are tubes that have been implanted in her left eye for glaucoma surgery. Zooming in, you can see this slightly altered reflection from the plastic lens inside the pupil and these tubes. And then on the front of the eye, there's some stitches from a glaucoma operation and a little white patch, which is covering where the tube goes out of the eye. And the tube at the top runs out under a little scleral patch onto a plastic plate. And the tube at the bottom runs out under another scleral patch, and the plate is hidden further down under her eye. And these are pretty standard glaucoma implants. It is quite out of the ordinary to have two tubes in one eye, but these are the kind of adventures that glaucoma patients sometimes end up going on. This is the contact lens with the mirror, which we call a gonio lens, looking at the trabecular meshwork where the iris meets the edge of the cornea. And you can see how the tube comes into the eye in that location, and the clear fluid disappears up the tube and onto the plastic plate. And these are some of the other things that we sometimes see under the microscope. This is some fluffy grey material on the front of the lens. Here it is again. And that's called pseudo-exfoliation material. And this is quite a common cause of a relatively aggressive type of glaucoma. It's a slightly more volatile and potentially serious type of glaucoma than the most standard primary open angle type. And these are pictures of pigment dispersion, where the back of the iris has been rubbing on the lens, and that dark brown pigment on the back of the iris has been rubbed off, and some of it's ended up on the inside of the cornea, and that's left little partially transparent parts in the peripheral iris. So these are quite lovely pictures of what pigment dispersion is. Sometimes that leads to glaucoma, usually in younger, short-sighted people. And these are pictures of other types of glaucoma when it's caused by other eye diseases. So this is inflammation in the front of the eye. This is someone who's got new blood vessels growing in the front of their eye. And this is someone who's had an injury, maybe from something like an elbow or a squash ball, something small and blunt. And they've got a cataract and they've got iris damage. And these things can all lead to high pressures in glaucoma. So those are the kind of things we're looking for in the front of the eye on the slit lamp. So the next thing that we usually do is put a bit of anesthetic in the eye, usually a bit of yellow fluorescein, and we check the pressure with this device called a Goldmann tonometer. And this is our gold standard, our most useful and common method for measuring the pressure. And most of you will be familiar with this experience. You have a numbing drop in your eye, and then the blue light, and this little tip comes up and touches the eye. And what's happening is that the tip of the little device, which is a kind of smooth plastic cylinder, it flattens the front of the cornea and it pushes the fluorescein out into a little circle. So by pushing on the cornea, it makes a little circle by pushing the tears away. And then it's got little prisms inside that split that circle into two half circles. And when we adjust the spring so that the inside of the circles are just touching like that, then that determines that the area of the circle, the diameter of the circle is 3.06 millimeters, which has been determined to be the size at which the surface tension of the tears and the rigidity of the cornea are equal. And so this is kind of the endpoint that we use to measure the pressure. So I've got a video that sort of shows you what it's like from our side. This is what the tonometer looks like, just looking down the inside of the microscope with the blue light on. And this is a video of measuring our volunteers' pressure. And you can see when the tip touches the eye, those green half circles come into view. And then I'm adjusting the tension on the spring. And when I turn the spring up, the tonometer pushes harder and the circle gets bigger. And then when I turn the spring down, the tonometer pushes less hard and the circle gets smaller. And then when I adjust it at the end to the correct number, the inside of the circles are just touching. I'm just showing you that again. So that's with the spring too high, too much pressure. That's with the spring too low and the circles are not quite touching. And then that's kind of the end point when we can measure the pressure off the dial on the side of the device. So that's kind of, we adjust it until we see something like that. Yeah, so that's what measuring the pressure looks like from our side of the microscope. And then we often pick up these little lenses and look further into the eye, and using our slit lamp, we can see the retina and the optic disc. And it is tricky to get a photo or a video of the back of the eye. You can see that the image is upside down. This is the left eye, and it's upside down, and everything's moving. There's too many things. So we usually use a camera, which gives us a wide field static view, but it's a two-dimensional view, and we can't pick up pulsations, and we can't zoom in very well. So a two-dimensional view of the optic nerve is useful. These photos are useful, but three-dimensional scans have become more important. Now, I'll just point out here that this person has this kind of orangey tissue around the edge of their optic nerve. So imagine that there are cells all through the retina, and they're sending a translucent nerve fiber across the back of the eye, and then it turns 90 degrees and goes back out through this hole. And so as these nerves come across the back of the eye and turn over the edge of the optic nerve, they form this kind of orangey tissue, which is the actual nerve tissue, which we call the neuroretinal rim. And everyone's got a neuroretinal rim. And when the rim gets thin, that indicates that there are fewer nerve fibers coming into the optic nerve from this in this sector, and the optic nerve might be thinned in that location. So in this person, the right eye has got a moderately big cup and a relatively thin rim, but there are no areas that are really definitely thinned. On the left side, at the bottom, that looks pretty thin to me. With my eye of experience, I would say that's a thin rim there, and that this part of the OCT scan is likely to be thin, and the visual field that we saw before shows a corresponding abnormality in the top part of the left visual field. So these are the OCT scans. Sorry about the weird buzzing noise. That's one of the downsides of doing OCT scans, is the screechy buzzing noise. And you can see that very quickly it's acquiring very high resolution, high magnification images of the back of the eye. Really only just took 10 seconds to get an incredible amount of data from the optic nerve. And these are kind of what the scans look like. So this is a cross section along that bright green arrow. And so these are the layers of the retina here and the retina here. And this is the hole in the back of the eye. And the nerves run across the surface of the retina, forming this bright layer. And then they turn and go back to the brain. And so this is the right eye, which is got a normal visual field, and there's a relatively big cup in the front of the optic disc. But when we quantify the amount of nerve tissue with these little blue arrows at different angles of the clock, these blue arrows are shown as the black line here. And you can see that mostly it's classified as having a normal amount of nerve tissue, forming a normal thickness or quantity of neuroretinal rim. This is the scan that we use the most to decide if someone has glaucoma. And it's a circle through the retina just outside the optic disc. And so there are nerves coming through from different parts of the eye. And as they come through this circle, they form this bright green, this bright layer on the surface of the retina. And then we measure the thickness of that layer between the red line and the blue line. And the thickness is shown as the black line down here. And so the black line is not normal, maybe a bit borderline, normal, maybe a bit borderline, and normal visual field, and a normal OCT scan. And we also scan the retina, and obviously the retinal doctors spend all day looking at retinal scans, but the glaucoma doctors spend more time looking at the optic nerve scan. But sometimes the scans of the central retina show us when the optic nerve cells in the central retina are involved. And in the right eye, again, there's no abnormal areas of the optic nerve layers. So now flicking over to have a look at the left eye and show you what abnormal glaucoma looks like. This is the left eye with a vertical slice through the optic disc. And remember, on the photo and OCT, the photo and the visual field, we were suspecting that there was a loss of nerve fibers in the bottom sector. And you can see that the amount of nerve tissue coming over the bottom edge of the optic nerve is very thin. And that's measured as being, almost zero and being abnormally thin. And so that sector at the bottom of the left optic disc has got a abnormally thin rim. And corresponding with that, there's thinning of the nerve fiber layer on the circle scan. And there are fewer nerve fibers in that part of the optic nerve that are coming into this part of the optic disc. And so this is kind of a typical pattern. Often when doctors look at different optic nerve diseases or different eye diseases, we're sort of looking for familiar patterns to decide whether this is glaucoma or whether it's a different disease. And this is a pattern that's very much indicative of glaucoma. This is the location that glaucoma develops. And one of the ways that we are confident about calling it glaucoma is when the structural abnormalities, the areas of optic nerve thinning, match the areas of visual field abnormality. And when they match well, that gives us confidence that this is glaucoma. And if they don't match, particularly if the visual field is worse than we expect it to be, then we consider, could there be another optic nerve disease? And so here is the visual field again, and just reminding you that this part of the visual field in the top inner part of the left eye matches this distribution of thinning of the optic nerve in the left eye. And take it from me that's quite a tight correlation, and that's good structure function relationship, and gives us confidence that this is a pattern of glaucoma. Gosh, I feel like I've raced through all that, so we could discuss these things some more if you have questions. But the point was, when we're measuring vision, we check the central vision, but it doesn't tell us anything about the peripheral vision. So we have to do a visual field, and it gives us an incredible precision and detail about all these locations in the visual field and the extent to which they are reduced or not. We use the slit lamp microscope to understand why the pressure might be high or low, and to look for causes for high or low pressures in glaucoma. Goldmann tonometry is our most common measure of pressure, and that's the little blue light test. And I hope I didn't get too technical explaining how that works. And then most of the time in glaucoma care, we are looking at the optic nerves, usually with an OCT scan, and deciding whether they are stable or getting thinner. And if they're getting thinner, then you might need a lower pressure. That's kind of an oversimplification. We're always in the back of our mind matching the structural changes of the optic nerve with the functional changes on the visual field to convince ourselves whether we've got the diagnosis right. Yeah. Lucy's asked, how do we determine whether glaucoma is on? In my talk, I sort of presented a snapshot of how thick the optic nerve is at one time. But for most of you who've got glaucoma, each time you go back to the clinic, you're getting another snapshot, and we're putting all that into a longitudinal series of snapshots to give an idea of the trend. And so over time, all of us are looking at patients with glaucoma and establishing, is it stable or is it progressing? And Lucy, you're quite right in asking, is it the OCT scan getting thinner, or is it the visual field test getting worse? That indicates that the glaucoma is getting is progressing. And the answer is both of those things should change together. Generally speaking, if you've got mild glaucoma, then the visual field is normal, and the OCT scan might be the only sign of damage. And in that mild glaucoma, the OCT scan will change before the visual field changes. But in advanced glaucoma, when you've got lots of abnormality on your visual field, the OCT scan is usually already very thin, and it can't get much thinner. So if you've got more severe glaucoma, the visual field test will change more obviously than the OCT scan. So the test that we find most useful depends on how bad the glaucoma is. And for people in between who've got a kind of mild to moderate glaucoma, we often need to check the visual field and the OCT scan to see whether the healthy areas are getting worse on the OCT scan and whether the sick areas are getting worse on the visual field test. someone with a pseudonym, Intrepid Overlander, has asked about why they are told not to worry if I miss the flashes. Yeah, that's a really good question, and that's a really it's a really key point in here that's really helpful to highlight. So the visual field machines are amazingly clever. They are really very sophisticated physiology, and they're not doing the same test for everybody. It's a really important point that as you do the test, the machine is learning what you can and can't see. And it is kind of zooming in to the machine and into the areas that you can't see and testing them more and testing other areas less. And so that, by doing that and not testing all the sensitivities at all the locations, it makes the test much, much faster. If we were testing all the sensitivities at all the locations, it would take 20 or 30 minutes and no one would do it twice. It would be so unpleasant. So the machine is learning and modifying the test based on what your reactions are. And it's trying to work out exactly what you can and can't see at every location. And as a result, it is presenting you with targets that are too dim to see. And that means that it's normal for everyone who takes the test, even someone with perfect vision, to miss about half of the targets because they're making them so dim that even a normal eye can't see them. And so the machine's even cleverer than that because it does practice trick. It does trick tests where it makes the same noise, but it doesn't send any light. And that's looking for people who are trigger happy and just pushing the button when they hear it instead of when they see it. So that's a really important point because even someone with perfectly normal vision will be missing half the targets because the machine learns what you can see and is just trying to work out exactly what level you can see or not. And so that's why it's really important to relax and only push the button when you know that you've seen the light. And because all of us doing the test are stressing out and trying to do the best job we can, and can often end up pushing the button when we think we might have seen a light, but that doesn't contribute to a better result. Yeah, that's a really helpful point to make. Thank you.
No, if the technician didn't put the correct lens for my eye, will that give a false result?
Yeah, if it's fairly close, if it's within a little bit. So yeah, I'll just repeat the question to make sure I got it right. But when you're doing a visual field test, usually it's the technician who selects the lens and puts it in the lens holder. And there are lots of opportunities for the technician to make a mistake and put it in the wrong axis or the wrong strength or the wrong eye. And I think your question is, how much does that affect the result?
Yes.
And if you're wrong by a lot, if the lens is wrong by more than 3 or 4 diopters, then yes, it will give an overall reduction in the sensitivity of your visual field test. It will not tend to make like new areas of abnormality. It will tend to just reduce the sensitivity at every place in your visual field. And so normally when that happens, because it does happen from time to time, we can normally spot when it happens because the result is reduced in that characteristic way. The sensitivity is reduced all over the visual field rather than a progression of the glaucoma, for example. And so then we can say, oh, looks like the wrong lens was used, or I wonder if they mixed up the lenses today or didn't change them after the cataract operation or something like that.
Regarding the pressure test, my ophthalmologist uses puffs of air to do it.
Sure.
Would you like to comment on that?
Yeah, well, there are several devices. I can think of, maybe 4 or 5 right now. And each of them has strengths and weaknesses. One of the things that's nice about the air puff test is that you don't have to put anesthetic drops in, and it doesn't touch your eye. But a lot of us have experienced, referrals from optometrists saying this person's ear puff pressure was high. Could you have a look at whether they're developing glaucoma? And when we measure the pressure again with other devices, we find that the pressure is not really high, and that probably the ear puff was reading wrong. And there isn't really a sort of a hierarchy of which device is best. We tend to say that they've all got strengths and weaknesses, and that sometimes if there are big differences between the devices, that gives us information about the mechanical properties of the eye, sort of gives us an indication of whether the eye has typical mechanical properties or atypical mechanical properties. So sometimes in our practice, especially if a patient is progressing on their glaucoma when we don't expect them to, we measure the pressure with multiple devices to see whether that indicates that we're measuring the pressure incorrectly. I think, though, that generally speaking, ophthalmologists use the Goldmann blue light one that I showed you more than other devices. That's sort of our gold standard for most clinical studies and so on. Yeah, Lucy asked about pressure changes during the course of a day, and yeah, there's a lot that is discussed about this issue. Oftentimes people get into a habit where they attend their ophthalmologist at roughly the same time of day every time they go to that clinic, and so we get a tiny snapshot of what their pressure is doing. And sure enough, everybody's pressure does vary, but the pattern by which it varies is unpredictable and differs from one person to the next. So again, if somebody's glaucoma is behaving unexpectedly and getting worse when we always measure the pressure to be 10 or 12, then one strategy is to bring the patient back at different times of day to check whether we are missing high pressures in the morning, for example. And so that is also a little bit impractical, because most of our clinics are only really open from 8 till 4 or 5, and you might be missing other times at night when the pressure goes up. So there's a gadget that has been marketed called the Eye Care Home. It might have a new name now, and it's essentially an eye care tonometer, one of the little bouncy beepy ones that are often used by nurses in the clinics as a sort of pressure check, but you do it to yourself at home. And there are downsides to measuring the pressure too much, because people can really get obsessed and stressed out about it. But that is quite a powerful technique for detecting big swings in the pressure at different times of day. The last thing to say on that is that because of the expensiveness of those home pressure devices and the fact that we can only really measure pressures during business hours, there's been a bit of work to come up with a shortcut. Like, how could you estimate the amount of pressure change in a quick period of time? And one of the tricks that people are using is a water drinking test. If you suspect that the pressure is going up at other times of day, you can ask the patient to drink a whole litre of water, and everybody's pressure will go up a little bit, but people with glaucoma will tend to have a bigger increase in their pressure. And so if you have a big couple of big glasses of water and your pressure goes from 10 to 25, then that indicates that your pressure is going up and down much more than most people. People with normal non-glaucoma eyes might go from a pressure of 12 to a pressure of 15, just a small increase. And people with glaucoma might increase to a dangerous level. And that's sort of as one shortcut for estimating how much the pressure varies at different times of day. Jan was asking about things that would indicate that the pressure is going up at different times of day. And that's really tricky because most of us can't tell at all what our eye pressure is. And generally speaking, the pressure has to be super high, over 40, before people get any pain or changes in their vision from a high pressure. So what things put the pressure, what things might indicate that the pressure is going up and down? I can't think of any symptoms that patients would notice that would give them an indication of whether the pressure was changing. But there are some types of glaucoma that are more likely to cause spiking variable pressures, like that pseudo-exfoliation that I mentioned, the kind of grey fluffy material that accumulates in the eye. The situation that makes me think that the pressure might be varying is when I measure a nice low pressure and the patient's obviously taking their eye drops because they've got side effects from their eye drops, and the pressure's nice and low, and yet the glaucoma seems to be getting worse. And that makes me think, oh, maybe the pressure's high when you're not in the clinic with me. And that might lead me to do a water drinking test or measure the pressure at other times of day to see if we can detect that and address that. And then Pauline's asked a question about whether carrying heavy weights or that sort of heavy straining exercise can put your eye pressure up. This happens to be something that I think about a lot. You might have seen a talk I did maybe several months ago now about tipping people upside down. And when you do really straining exercise, like lifting a heavy weight, or straining like you're constipated, or straining like you're doing that kind of weightlifting exercise, that's called a Valsalva, and it's where you kind of close your airway and pressurize your chest. And when you do that, the pressure in the veins in your head goes up slowly and steadily over 10 or 20 seconds. So when you do weightlifting type exercises, I would expect the pressure in the veins in your head to go up. And when the venous pressure goes up, the eye pressure goes up. And the same is true when you go upside down. Your vein pressure in your head goes up, and so does your eye pressure. But I think just as much as the eye pressure, the pressure in the brain and the optic nerve goes up to the same extent. So the venous pressure drives the head pressure and the eye pressure up to the same extent. So it's not causing a specific increase in pressure in the eyes. It's just making the whole head pressure, all the tissues of your head, equally increased in pressure. And that should not be so bad for people with glaucoma. People with glaucoma are always told to avoid yoga and putting their head down, because when you put your head down below your heart, your eye pressure does go up. But I think that is probably an exaggerated risk, because if all the pressures in front and behind the optic nerve go up by the same amount, then it's not putting too much stress on the optic nerve. Yeah, so I guess heavy lifting is fine for glaucoma patients, but there is one group that should maybe avoid that, and that's people who have a low pressure after surgery. If the pressure in your eye is really quite low, then straining and increasing the venous pressure could cause a bleed in your eye. So often people who've got a soft eye after surgery are told to avoid heavy lifting and that kind of exercise. Sandy has asked a question. Yeah, Sandy's asked a question that's along the lines of the one about straining and tipping upside down. It's, if you've got glaucoma in one eye, is it better to sleep with that eye up or with that eye down when you're asleep? And that's a really good question. And I've heard some professors of glaucoma describe patients who sleep with one eye down, sort of scrunched onto their fist on the pillow. And that's their habit, is to just kind of squash their face onto the pillow and onto their hand. And that's the eye with glaucoma. And they've speculated that maybe sometimes people have habits that lead them to squash their eye or put the pressure up in one eye more than the other and cause them to develop glaucoma in one eye and not the other. In my tippy upside down study, oftentimes the patient had their head turned to the side while they were tipping up and down, and the eye that was further off the ground tends to have a lower pressure than the eye that is down. But again, I think the venous pressure in the optic nerve is also higher in the lower eye. So I'm not sure. I'm not sure yet. I can't give a definitive answer on that. I think it is true that if you're the sort of person who likes to squash their face on their pillow while they're asleep, then probably squashing your eye with glaucoma could put the eye pressure up more than the other pressures in your face, and would be not advisable. But there's also this challenge that changing what you do when you're not conscious is extremely difficult. Trying to change your sleep habits is very difficult, and if it meant that you just didn't sleep well, then I think that would have its own negative consequences. Paul asked about whether surgery is painful, and nobody likes doing painful things because it's unpleasant for the patient, but it's very unpleasant for us surgeons as well. So if it hurts, then we're probably doing it wrong. And most people can tolerate surgery under local anesthetic. And there are different sorts of surgery, so I wouldn't want to, go into too much detail about all the different surgical choices. But whatever surgery we're doing, we really don't want a stressed, painful, unhappy patient, because that causes stress and discomfort for the surgeon too. And everything is more difficult and more risky when the anesthetic is insufficient. And so a lot of people can tolerate quite big operations on their eye under local anesthetic, and that's often a safe option, especially as people get older, into their 80s. But some people just think, I'm not going to be able to relax, I'm not going to be able to tolerate this, and they can have a general anesthetic if that's the safest, best option for them. There's a question from Gerard about bleeding behind the retina. So I'm not sure that, bleeding behind the retina is quite a rare thing, but little bruises and bleeds within the retina are quite common from a vein occlusion or a diabetes. And so I wouldn't want to speculate too much on what sort of bleeding you're talking about. There is a rare situation where people have a bleed behind their eye, in the tissue behind the eye, in the sort of fat and muscles behind their eye. And that's called an orbital hemorrhage. And that can put the pressure up in the eye, but also the pressure up in the optic nerve and all around the eye. And so conditions that increase the pressure in the eye, but also all around the eye, don't tend to cause glaucoma because they're not pushing backwards on the optic nerve. The pressure is equally high on both sides of the optic disc. Next question from Paul was about vasovagal and pre-syncope. Those are kind of medical terms for when your blood pressure goes low and you feel like you're going to faint. And so a vasovagal and pre-syncope indicates that your blood vessels are dilated and your blood pressure has dropped. And yeah, and for poor, maybe dizziness, blurred vision, and nausea. So those kind of nearly fainting episodes are not very common and not very predictable, and that makes them quite hard to study. So there isn't any really strong clinical evidence one way or the other as to whether those kind of experiences are bad for people with glaucoma, because we just don't have many patients who have both glaucoma and fainting. But there's several lines of kind of clinical evidence that glaucoma doctors like to discuss about how low blood pressure might be a cause of worsening glaucoma, and that the concern is that if your blood pressure drops more than average, more sort of abnormally low, when you're in bed asleep, then your heart might not be pumping blood hard enough into the eye, and the optic nerve might be going without. Wendy's asking about whether a very slow pulse affects pressure in the eye, and the answer is it should not. A slow pulse might give you a low blood pressure, but it should not affect your venous pressure or your eye pressure. And the pressure in your arteries, which is the blood pressure that people measure with a cuff, the pressure in the arteries and the pressure in the eye are not closely related. So having a slow heart is not likely to be relevant to your eye pressure. Ocular migraines, yeah. Well, that's a big question, but that's something I have a lot of patients with migraine because I do a bit of neuro-ophthalmology as well as glaucoma, and most people who have visual aura from migraines, that's where people get zigzags and lights and gaps in their vision that last for 20 minutes or so, and sometimes happen before a headache. Those visual auras are usually coming from the back of the brain, so this part, so quite a long way from the eye. And there are some relatively weak but definite associations between migraine and some types of glaucoma. And it's thought that migraine is a condition where the blood vessels spasm and then relax, and the spasm causes poor blood flow to the brain and gives you funny visual experiences, and then when they relax you get a big rush of blood and that gives you the headache. And that's a kind of primitive understanding of how migraines work, and it's thought that vasospasm in the brain might relate to vasospasm in the eye, and the connection with glaucoma might relate to sort of unpredictable blood flow or dysregulated blood flow in the eye. But there's also a different type of migraine where people get a truly ocular migraine where the vasospasm happens in their retina, and the symptoms are quite different. They don't get zigzags and colors and patchy visual field. They just lose vision in one eye, and so that's quite rare, a retinal migraine like that, and that indicates something quite out of the ordinary about the blood vessels in their eye, and that could very well be associated with more serious vascular problems or glaucoma damage. But I don't think I've got any patients with that type of definite retinal migraine. It's a pretty rare thing. Most people who have ocular migraines are really talking about vasospasm and visual experiences coming from the occipital lobe of their brain.